There was very poor interrater reliability, meaning you sit two psychiatrists or analysts in front of the same patient. They rarely agreed on the diagnosis. They rarely agreed on how to treat the patient. In 1980, when DSM-3 is published, it places an emphasis on reliability over validity. And so you have 297 different disorders listed in DSM-3, when just 2 years prior, the research diagnostic criteria was published in 1978 that showed that we had maybe 12 or so valid, scientifically validated psychiatric diseases. So you go from 12 valid conditions in 1978 to a book in 1980 with almost 300 different disorders. How does that happen?
Welcome, Mark. Thank you for being here, Mark Ruffalo. Fifth guest on this phenomenal podcast I've put together called "What the Fuck Is Life." It's an honor and a privilege to have you. Thank you for risking so much by being here. So today, Mark is here to speak to pluralism, essentially, both in psychiatric treatment and psychological treatment, and also in relevance and reference to the history of the DSM, where nosology goes, where the criteria goes, and of course, how we relate it to etiology and disease, when right now that seems to be something that's not as included. So again, thank you, Mark, for being here. It means a lot to me to get all these conversations off the ground and to kind of have faith in what we're building of trying to make therapy and mental health treatment more meaningful and integrative.
Yeah, absolutely. Thanks. No, thanks for having me, Max. I love what you're doing with the podcast here. And
Oh, stop it.
that I think it's been great so far. So I'm honored to be here.
Yeah, so far so good. Yeah.
Yeah.
So you're here today to speak to, again, is there something most passionate you feel in reference and relevance to this pluralism, or again, how the DSM has maybe helped and harmed us?
Yeah. I think, I think I want to talk mostly about how we conceptualize health and illness and why that's relevant to psychotherapy and psychoanalytic approaches to psychotherapy, and really the importance and the need for a pluralistic approach to psychopathology. And what I mean by pluralism is basically we don't treat every patient or every problem the same. And so I want to touch on a few of these issues, and we'll see how it goes.
Okay. So where can we begin? We've certainly touched on this subject before with other guests in terms of there seems to be a consensus, right? That the bifurcation, trifurcation, quadrification, making up words of how people are treated either biologically, physiologically, psychologically, sociologically is a problem. And so we want to be more tolerant, both in our experience of a patient or a client. At the same time, we want to have adequate training, right, for a mental health professional, which is a whole nother, I don't know if we'll get to that today, because what does that word mean? So in essence, what is it that you feel most compelled to speak to in inviting the pluralism into the fold?
I think it's really easy to get sucked into sort of a silo intellectually, and philosophically when it comes to training and work in mental health, right? I think we see this all the time in the psychoanalytic world.
Yes.
And I think it's really been to the detriment of psychoanalysis. I think you can also find silos in other disciplines. And so I guess I'll start with, a historical word of warning or a caution from history. I love history of psychiatry and history of psychoanalysis, and I teach the residents about this. Just finished up a seminar in history of psychiatry for the residents at UCF. So back in the 50s, in the 60s, when psychoanalysis was in its heyday in American psychiatry, where most psychiatrists were going on to train in psychoanalysis formally, and really, to make it as a psychiatrist in the US meant that you went into the private practice of psychoanalysis. That's what everybody aspired to do. And it was a lucrative job, and it was a job with significant esteem and privilege and the like. But so back in the 50s and the 60s, a lot of analysts would treat patients who we would now describe as having a bipolar illness, a bipolar spectrum illness, and, treat them in analysis 3 or 4 or 5 times a week. And if you know anything about bipolar disorder, it's a cyclical illness, right? Emil Kraepelin distinguished bipolar disorder from schizophrenia. Those were the two major psychiatric diseases that Kraepelin described, right? And he looked not only at symptoms, but to course of illness to Kraepelin was very important. And bipolar illness is a cyclical illness by its nature. It comes and goes. A person goes into depressions and then they come out of them and they have manic or hypomanic episodes as well. And so what would happen when these analysts were treating these patients, now this was before the advent of psychopharmacology, or right around the time psychopharmacology was coming on the scene, is you'd have a patient that we would now call bipolar or cyclothymic, and they'd come out of a depression and they'd be doing just fine. And the analyst would take the patient to grand rounds and present the case and say, look at how I've cured this patient. My interpretations, cured this patient of his mood cycling. And in reality, we know that bipolar illness is a largely genetic, biologically mediated disease, and psychoanalysis doesn't really touch it. And so history is replete with these sorts of things. And so when I talk about pluralism, what I mean is that we have to look at particular problems. And I think that diagnosis in psychoanalysis is, and always has been to some extent, controversial. Some analysts really don't like the idea of diagnosis, or they don't value it very highly. They think it's relatively unimportant. The patient's either neurotic or psychotic or somewhere in between. And I take a very different approach. I really like Kernberg's work because Kernberg really tried to merge psychoanalysis with classical German descriptive psychiatry. So if you read Kernberg, obviously he thinks it's very important to identify the different illnesses or conditions or diseases. And then treatment depends, at least in part, on what the type of condition is. So in some, you don't treat every patient the same. And so this gets into what do we mean by a diagnosis? What is a disease? Psychiatry, psychology, mental health.
Right.
And these are all important questions. But I think it's very easy to get siloed in what's one's thinking if you only see a particular type of patient in your training or in your clinical work. So an old mentor of mine, Bill Meyer, who has since died, but he was a wonderful psychoanalytic therapist and a social worker. He was on the faculty at Duke for many years in the psychiatry department. He said that it's best to have two different types of training experiences. One where you see a few patients for a long time, and then one where you see lots of patients for a short period of time, either in an emergency department or on an inpatient psychiatry unit. So you get a broad range of different types of clinical experiences, because that type of exposure really allows you to realize that what we call mental illness, what we call psychopathology, isn't just a single thing. It's a very heterogeneous category.
Sure.
You have illnesses in the DSM that are bona fide neurological diseases like Alzheimer's disease. Then you have conditions that are mostly neurological and organic, mostly genetic, like bipolar illness, schizophrenia, classic obsessive compulsive disorder, autism. Conditions that are largely environmental in their causation, like personality disorders. And so if you go into the field, or if you go into practice thinking that you can treat all these problems in the same way, I think you're bound to fail. In fact, you're bound really to hurt people. And I think that I don't think this is appreciated enough. I see, we're on Twitter together, or X, and
We're very healthy, yes.
and all these problems, they just tend to get clumped together. And people just talk about mental illness like it's one thing. Well, mental illness isn't just one thing. Mental illness is many different things. And it's really just an accident of history that we have this book called the DSM, and all of these things get clumped together. And so it really goes back to Kraepelin, who distinguished between two different types of disorders or illnesses. One type, which he referred to as disease processes. It's a really beautiful word in German, but I can't pronounce it. These are mostly biological, organic, genetic diseases. And in this category would be, like I said, schizophrenia, bipolar disease, autism, obsessive compulsive disorder, severe unipolar depression, and the like. And then the other type of illness he called a clinical picture, a constellation of symptoms that occur together. They're not classic diseases in the medical sense, but we can diagnose them. They're mostly environmental in their causation. And in this category, you would find what we now call personality disorders, milder types of problems, neurotic illnesses or conditions. And the DSM is comprised of both types of conditions, right? And so I think you run into a lot of problem when you treat a type A problem like it's a type B problem, or a type B problem like it's a type A problem. And it's probably caused, like I said, a lot of harm throughout the years. And so when we think about why we have the DSM system that we have today, you either love it or you hate it. And I'm growing increasingly not to like it at all. But it goes back to a period of time in psychiatry's history where there was a lot of infighting between the psychoanalytic wing and the biological wing of psychiatry in the 1970s. And so psychoanalysis had reigned supreme for decades. And then you have the young guns, the biological psychiatrists who come into town with their lithium and their thorazine and their imipramine, and they start treating patients and getting pretty good results with patients that analysts had tried to treat for years and they weren't really responding. And all of a sudden you start a bipolar patient on lithium, and then within a week or so, they look pretty cured. So there was a lot of infighting within psychiatry in this era. And then you also had the anti-psychiatry movement led by people like Thomas Szasz and R.D. Laing and others, Erving Goffman, Michel Foucault in France, and then David Rosenhan publishes his famous study on being sane in insane places, basically alleging that psychiatrists couldn't tell the difference between who was healthy and who wasn't in psychiatric hospitals. The study was fraudulent, but that's a story for another time. But anyway, so psychiatry was starting to look a little silly. There was very poor interrater reliability, meaning you sit two psychiatrists or analysts in front of the same patient. They rarely agreed on the diagnosis. They rarely agreed on how to treat the patient. In 1980, when DSM-3 is published, it places an emphasis on reliability over validity. And so you have 297 different disorders listed in DSM-3, when just 2 years prior, the research diagnostic criteria was published in 1978 that showed that we had maybe 12 or so valid, scientifically validated psychiatric diseases. So you go from 12 valid conditions in 1978 to a book in 1980 with almost 300 different disorders. How does that happen? But how do we go from about 12 validated conditions to 300? There's a story to be told about that. And so, what do I mean when I say valid? My colleague at Tufts, Nasir Gami, likes to use this example. So Max, you and I could agree on how to define a unicorn. Right? We could say it's a mammal, it's white in color, it's got this unicorn-like thing coming from its forehead, right? And we'd agree that that's how we define a unicorn. And if we see one, we'd agree that that's the label that we should use. We would call this a unicorn. The problem is that unicorns don't really exist, right? So you have a reliable construct or concept, but it's not valid. It doesn't really exist in the natural world, in the biological world or the psychological world. And I think that this is exactly the case with the majority of what exists in DSM. So Eli Robbins and Samuel Gauzet in 1970, I believe, they published a paper on validity in psychiatric diagnosis. And because there's no biological tests in psychiatry, right? We don't send our patients for MRIs. We do so if we want to rule out a brain disease or neurological disease, but there's no blood tests or organic tests. How do we determine what's valid and what's not? So Robbins and Gauzet published this paper that becomes very influential in studies of validity of psychiatric illnesses. And they define a particular way of establishing validity for diagnosis. And they say, we look at symptoms. Now, it's not enough just to look at symptoms because there's a lot of overlap between different conditions in terms of symptoms. But symptoms, number one, and then discriminant validity. Does condition A differ from other conditions? So discriminant validity. The next thing we look at is course of illness, which is what Kreplin believed was very, very important. Longitudinally, what happens to patients? Do they get better? Do they get worse? Is the illness recurrent, cyclical? Does it come and go? And this was what Kreplin distinguished. This is how he distinguished bipolar from schizophrenia. is it wasn't necessarily on the basis of symptoms. A lot of bipolar patients have really psychotic symptoms and they look sort of schizophrenic. Kreplin said we need to look at the course. Schizophrenia is a progressive, deteriorative disease that gets worse over time. Bipolar disorder, like I said already, it's cyclical. Person goes into depressions, they come out of them, they experience manias, usually short term, and then they stabilize. And that was how Kreplin distinguished bipolar from schizophrenia. So we have symptoms and discriminant validity. Does the condition differ from other established conditions? And number two is course of illness. Number three is treatment response and or biological markers. Now, not all conditions have biological markers. Some of them do. As a proxy for that, you can use treatment response. What happens when you give a particular medicine or a particular type of psychotherapy? Does the patient get better? Do they get worse? And then lastly, genetics. And so in the past half century, we've had a lot of data on genetics and psychiatric illnesses. Robbins and Gouset published this paper, I believe in 1970, establishing this criteria. And so if you use this type of criteria to look at DSM diagnoses, we realize that if we're being very conservative about it, there's only about 12 or so disorders that really are valid, scientifically valid diseases or disorders. Disorder is sort of a weasel word for disease, and we can talk about that a little bit, but the rest of them are scientifically invalid. What do I mean by that? They can't be distinguished from other conditions. There's very poor data when it comes to the other validators, and so they don't actually exist in the natural world. So I'll give an example of something that we see all the time. Patient comes in and they complain of depression, anxiety, problems with focus, attention, and concentration. Now, if you're looking at this patient from the perspective of DSM, you may be liable to diagnose them with three different disorders. They have a depressive illness, they have an anxiety disorder, and they have ADHD. And DSM says that's totally fine. Basically, DSM tells us, with very few exceptions, diagnose as many conditions as the patient meets criteria for, with few exceptions, right? You can't diagnose schizophrenia and bipolar at the same time, but that's the exception. It's not the rule. So what happens? The patient gets diagnosed with three different disorders. Let's add insomnia in the mix. They have insomnia too. They get diagnosed with three different disorders. They get put on an antidepressant for the depression, an anxiolytic for the anxiety. They're put on a psychostimulant for their attention problems, for their so-called ADHD, and then they're put on a medicine for sleep. They're put on Seroquel for sleep, an antipsychotic, let's say, for sleep. So they walk into the office, they get diagnosed with four different problems, and they get put on four different medicines. I'm not talking about psychotherapy now. Psychotherapists will do this too, and they'll diagnose people with multiple different problems. Now, the problem with that is that in nature, people generally are not unlucky enough to develop four diseases at the same time, right? People usually develop one illness. And so Mario Maj, who's the editor of World Psychiatry, the journal World Psychiatry, he published a paper about a decade or so ago titled The Problem with Psychiatric Comorbidity that captures this problem, right? Is that let's think about what else might cause all of these symptoms: depression, anxiety, attention, focus, concentration, and insomnia. Well, the patient could have a mood illness. They could have depression. Depressed people often get anxious. They often have trouble focusing and attending to things, and they often have problems with their sleep. They could have cyclothymia or mild bipolar illness, where they have mood symptoms, anxiety symptoms, problems with focus and attention. When people get manic, hypomanic, or depressed, they have trouble concentrating and focusing, and they also are impaired in their sleep. They could have borderline personality disorder or another personality disorder, which causes problems with mood regulation, anxiety, often in interpersonal context. So my perspective is DSM gets this totally wrong. There's no hierarchy of diagnosis. We need to look at hierarchy. We're liable to misdiagnose a lot of people and mistreat a lot of people. Let's just say in this example, the patient actually has borderline personality. What do we know from the empirical data? Borderline personality is not treated with medicine. Patients don't generally get any better with medicine. You might be able to affect some of the symptoms with antipsychotic or mood stabilizing drugs, but borderline personality is a disorder of interpersonal functioning, right? It's a disorder of attachment. And so it's not treated with pharmacotherapy. So the patient comes in complaining of four different symptoms, but we're mistaking symptoms for diseases, when in actuality, it's likely the case that there's one cause of all of these symptoms, whether it's cyclothymia, borderline, another mood illness, another type of problem. And that's why I think that being thorough in diagnosis is so important. We can get ourselves and our patients into a lot of trouble if we if we don't know history and if we don't appreciate the nuances of diagnosis. And I think sometimes, I think historically, and I'm coming down pretty critical on psychoanalysis here, and I'm not really, generally speaking, I'm not critical of psychoanalysis, but I think that historically people have been, I'm going to say kept in therapy. They're not necessarily kept in therapy, but the analyst or the therapist might recommendation that we continue therapy for years. And in fact, the treatment, it might get much better with a different type of treatment, and they might get much better very quickly with a different type of approach. So when I say pluralism, I mean matching the treatment to the particular type of problem based on the empirical data, the scientific evidence, and the like.
So there's obviously, that was a hell of an introduction. So first of all, you broke the record. It's now Thursday, May 15th. That was fascinating. It's the way that you organize and orient yourself to etiology and nosology of disease is unique insofar as your tolerance for history. As you said, it's quite obvious that you're passionate about that. Where it's relevant to me and to try to bring it into the fold of, let's call it contemporary treatment. And also, obviously, I'm biased as an analyst. I'm trained as an analyst and practice as an analyst, but try to be integrative or inclusive or, hold on to things lightly. There's so much there insofar as trying to summarize a little bit, the dilution of meaning and causality and overdiagnosis, 100%. I think that would be a non-controversial statement. The criteria of the directionality of the disease, like you said, be it longitudinal or cyclical, the course, how it's demarcated symptomatically, whatever the word would be, in its symptomatology, how it's demarcated in its presentation, and also in its response to pharmacotherapy, I think is also a meaningful information that's lost on many people on my side of the field. Obviously, my doctor, I'm not a physician, I'm a clinician, and more. As you said, there were four things. It does need to be, I agree with you, and included training does need to be more robust. Awareness and tolerance and attunement to the reality of these complications. I always like the work from information theory where there's complications inside a switch watch, but complexity and how traffic emerges from an interstate. And there's a difference between complication and complexity. All this stuff needs to be appreciated. Where you got spicy, and where I hope the listeners start commenting so we can get those views, is when you speak to what disease or disorder, another conversation, exists or not. The unicorn's a great example, or you make me think of like the elephant metaphor where all the blind men are standing around the elephant, grabbing the tail, grabbing the trunk, grabbing a leg and saying, well, what is this type of animal? But they can't see each other, see it. Certainly that's true. And the investment in causality in effect, right? Putting the cart in front of the horse is very common. The Tylenol metaphor comes up all the time, right? We're not treating the infection, but the symptom. The trouble I see in what you're saying, and this is certainly worth having the conversation if you feel safe to, who am I to invite this conversation? I don't know, is how you would demarcate these diseases. Number one, that's there, but then I guess how you would treat them, right? So because there's so many, I think, of our colleagues, some friends of ours, or even people generally internationally in the field would say, what do you mean ADD or ADHD is it doesn't exist? In my experience, I could speak anecdotally where I've certainly had patients with unipolar depression that have had satisfied the criteria for ADD, but it's emerging from a depressive constriction, inhibition, prohibition, et cetera, where the capacity to self-advocate or exert energically is robbed of them because of inner conflict to conceptualize it psychodynamically. Does that qualify, for ADHD? I don't know. Would they benefit from a psychostimulant, like you said, and start mediating dopaminergic pathways? Probably, but who wouldn't? Coffee is a hell of a drug too. That's right. And so it gets really messy and complicated. I'm not trying to have a cop out. I hope you see. I'm trying to have a good faith conversation, but I'm hearing the echoes of the 5 people who watch this podcast saying, fuck you, Mark. And so I'm curious to bring it back into a dialogue here of how do you manage this when you said you teach, which is so wonderful that you teach at UCF. You're helping. When I spoke with our colleague Doug, who's a psychiatrist, we spoke to the pluralism of how do you celebrate phenomenological psychiatry and move away from these extremes of biological reductivism and postmodernist gobbledygook And there is a swing towards integrative. It's small, but it's loud. Hopefully, I want to make it louder. So all this is to say, how does this affect your teaching? How does it affect your patient work if you're seeing patients? How do you manage all of that? Because to maybe put it a little bit more simply, we can move away from the DSM and use the PDM. Are you directing, you're saying this patient has one cluster or one disease or one disorder, and then I'm going to treat it pharmacologically and psychotherapeutically, and you're using the evidence to support that. How do you handle it if a colleague says, no, Mark, you're cuckoo, that's not right? I'm genuinely
Yeah, yeah,
curious
yeah.
how you manage all that.
Yeah, yeah. I guess I'll
I know I said a lot, but you said a lot, so what the fuck?
absolutely right. What the fuck is life? But
Thank you. Hashtag.
yeah, it's interesting. I teach psychiatry residents about psychotherapy and history. And previously, I've taught graduate students about psychopharmacology. I developed a course in basic psychopharm for social workers.
Which just very briefly is lost. I agree with you that, and Doug and I spoke to this, it's not, it is a shame, I'll just say it that way, that clinicians aren't taught any form of psychopharmacology unless you take it as an elective, but you
Yeah,
usually have to be hungry to learn it. And the fact that they're not speaking to back to something hopefully everyone can agree on is that the brain and mind, the monistic, approach of, dual aspect monism, it's come back. We know it's the brain and mind. This isn't Cartesian dualism. And so pharmacology should be taught to clinicians as well, I would say.
definitely. What I started out saying makes it sound like we have sort of definitive evidence, when in reality, things are nuanced and we're still learning things about psychopathology and how to treat it and what causes it and the likes. A little bit of humility is important here, right?
Sure.
I think, one thing that is rarely taught these days, that's really important, is patient selection. Who gets what treatment? I think so often now what ends up happening in practice is a patient comes in for therapy or psychodynamic treatment, and the assumption is that the patient should be given therapy. And that's how a lot of people practice. And I actually really disagree with that model or that way of working or thinking. I think it stems from a sort of postmodern relativism about truth and a biopsychosocial model that is not all that scientific, and we can get into that. But the idea is that, well, if everyone has a personality, if everyone has some psychological or psychosocial contribution to their suffering, that everybody gets therapy. And everybody should get therapy. And I actually think that there are certain patients who don't get any better in therapy. There are certain patients who actually get worse in therapy. And we don't talk about this enough. If you try to treat a patient with a severe melancholic depression in psychotherapy, they're not going to get any better. And in fact, in some cases, they're going to get worse. And this is the type of patient who generally responds to ECT. It's about 60% of patients who get electroconvulsive therapy have melancholia, the disease called melancholia, which isn't in the DSM. Right. But if you're trained in social work, and then let's say you do psychoanalytic psychotherapy training, and you never worked on an inpatient unit, you never worked with psychiatrists, which is probably the vast majority of people who end up becoming therapists.
Yes.
You've probably never seen a case of melancholy in your life. You may never have seen a case of severe bipolar illness or schizophrenia. Maybe you've seen one or two. I think that's a big problem because we can't conceive of things that we've never seen.
They're experienced or felt.
Exactly. Experienced or felt or had firsthand knowledge of, maybe. So I think it's important to have, like I started out by saying, a breadth of experience, not just a depth of experience, but a breadth of it as well, with different types of people, different types of patients, different types of settings, right? I sometimes talk about how theory often follows the clinical experiences of the theorists, right? So you have Heinz Kohut, father of psychoanalytic self-psychology, psychiatrist, working in private practice in Chicago, seeing mostly high functioning narcissistic Chicago businessmen, people who they may have a narcissistic pathology, but they are on the healthier end of the spectrum, if you will. And he develops an entire model of psychopathology based on treating a particular type of patient, a higher functioning patient in private practice in Chicago. Then you have Kernberg, who I think is a great mind, but he trains on inpatient units with severe personality disorders, with patients who are in the hospital, who probably have a lot of aggression, who probably do have excess aggression. And maybe some of that aggression is attributable to the fact that they're locked up in a hospital. And he develops a model based on a particular subset of severely ill patients.
Right. It's not research, it's me search.
Yeah, yeah. And so, my favorite psychoanalytic thinkers are those who attempted to study their ideas scientifically. So I'm a big fan of John Gunderson. I was actually just in his office, his old office at
Oh, wow.
McLean Hospital at Harvard last week, actually. Gunderson, for listeners who don't know, he identified borderline personality disorder as a discrete syndrome, operationalized it. It's because of him, it's in the DSM, and he studied it empirically. He showed that it met all of Robbins and Gouzet's criteria. It has good discriminant validity. It has a course of illness that's predictable. It responds in predictable ways to treatment, and there's a genetic diathesis to it. And so, I rarely get into disagreements with colleagues about this. Most of my colleagues now are in psychiatry. Most of them, generally speaking, have a decent sense of sort of the importance of empiricism. And I think that's lacking in some other areas in therapy. It doesn't mean that psychiatry gets it all right. It doesn't. I mean, psychiatry gets a lot of things wrong too. But I think what we ought to do is focus a little bit more on what the scientific evidence is for what we believe and what we how we practice.
Well, I think those metrics, I'm sort of learning from you even just today in this conversation, those metrics certainly seem, what's this word, datable. They seem amenable to being validated. They seem amenable to truth. There's a veracity to saying, especially when it comes to something as tangible as pharmacotherapy. If you say, you don't have to do, we know the trouble with placebo or no treatment at all doesn't really work, but you can certainly see that giving somebody who, melancholic, severe, malignant melancholic depression, if you've experienced it, seen it, or felt it in the room, the consulting room, you can see the limitations of an SSRI versus ECT. And ECT is a great example too of something that's been bastardized,
Yeah,
demonized, when it
yeah,
is such an effective treatment, and the research shows that. But there's so much shame and embarrassment, a different topic about stigma, so people don't even bring it into their practice as clinicians or physicians, let alone do patients have access to it. They see, and think of what, again, a brief aside, think of what Hollywood has done to it, even in the year 2025, where people still think it's shocks and not, and it looks like an EEG, if you're familiar with that. And it's very acute and very specific. And it really, really helpful and affordable and scalable, but we don't talk about it. So I totally agree with some of the things you're saying in that way of how do we, almost to say what mobilizes me in this podcast too, how do we expose clinicians and physicians alike, and also patients, to the terms of psychological literacy in the culture, which is a whole other
yeah,
conversation, of to all these realities, like you said, holding on to things lightly, to that it's not just biology, it's not just neurology, but it's not just sociology, and it's not just environment. It's quite obviously all the above. What I was saying is that, again, holding on to things lightly and ensuring that we include all of these exposures to, be it, like you said, short term with lots of patients or long term with the specific patients, it does inform us in meaningful ways, which is to say, what are we all speaking to? The outcome or the capacity to heal or help, or is that too strong a word, heal a patient, and when to know what to do. I think, again, like you said, if your patients are walking, I think I've had a mentor say this in my analytic training, or maybe a colleague has said this to us, where if they're walking into your office and you're in private practice or even in a group practice or a clinic, that right away puts them in a different position, right? Demographically, ideologically, pathogenically. If they're walking in, they got on the bus, they got on the subway, they got in their car. That's totally different than someone, as you said, melancholic, psychotic functioning or psychotic level of melancholic depression, borderline catatonia, let's say. Or, it's, I think of Oliver Sacks. I really like Oliver Sacks and his writing and what he's exposed in terms of the meaning and function inside of suffering. Again, I'm partial towards being an analyst. At the same time, the tolerance for, like you said, if this person might need, Haldol, this person might need Thorazine, this person might benefit from, lithium is going to be more effective than some forms of course, or most forms of therapy, or they go hand in hand if you really want to be diplomatic and inclusive. The bottom line being is there has to be a clinical humility, might be the phrase, of letting ourselves be educated and letting the heterogeneity of all this and idiosyncrasies of each patient come into the room. I appreciate what you're saying in terms, again, to give you back the mic, as we're fighting for it, because we both like to hear ourselves talk today, uh, that we have to be more tolerant of these Venn diagrams, these Venn circles, these concentric circles of disease when we're listening. That's the thing that I've learned. I did keeping it on the eye, doing a master's in social work. My doctorate technically is clinical social work, but I did my dissertation in psychoanalysis and then analytic training. But to just feel the tension in those schools, like you're saying, back to the siloing, it's so bad and it's internecine, it's mutually destructive. And who's the one it costs the most? Not only the taxpayer in terms of the cost of healthcare, but the patient. And so there's so much to be said in tolerating not knowing, okay with not knowing what we don't know.
Yeah, yeah, yeah. Yeah, yeah. And so, integrate psychotherapy training in psychiatry residency programs. That's been a requirement forever. And it's perhaps it's an ACGME requirement
Okay.
that
Yeah, basic
psychiatry residents
confidence. Yeah.
develop at least basic competence in several different modalities of therapy. Now that differs significantly on the residency training program, but they're required to be exposed to it.
They don't bring you in because of your psychopathology. That's
I'm a
what I thought you were saying.
non-psychiatrist to teach about
Yeah. Okay.
psychoanalytic psychotherapy.
You never know.
Presumably, yeah, yeah. Um, but we don't always, the opposite isn't always true. In fact, I think you could do an MSW today and get no exposure, zero exposure to psychopathology, biological approaches to treatment,
In the tri-state
diagnosis.
area or New Jersey, New York, where I'm familiar, many schools, and as a clinical social worker and what I went through, you can be a general practice at I think all the schools at this point, and not be exposed to training in any form of clinical or psychopathology, but then still become a licensed psychotherapist.
Yeah.
Oh boy.
I think a lot of this, at the risk of getting too philosophical and esoteric, is I think a lot of it boils down to a postmodern relativism about truth. We may disagree here, I'm not sure, but I think there are okay. There are some people in the social work world and also in the psychoanalytic world, for instance, who actually don't believe that. They say it's unimportant to diagnose the patient because they just don't believe in truth. They're relativists about what is true and what is not true about psychopathology. And some are really social constructivists, where there actually is no objective reality when it comes to psychopathology. Everything just happens in between the patient and other people, in between the patient and the analyst, the intersubjective ideas, right? Which is really um, it's really a postmodern philosophy. And so some of my favorite authors recently have been
Sure.
critics of postmodernism in psychiatry and related fields. So John Mills, who you may know of, psychoanalyst and philosopher. My friend Nasir Gami, who is a psychiatrist, but has been very critical about postmodern trends in psychiatry and related fields. So if you don't believe in truth, if you don't believe there is actually no objective reality, that all of it is just a construction, well, it doesn't matter if we diagnose the patient. The diseases aren't real. It's just the patient relating to others in the world. And the pathology, if you will, exists in between the patient and other people. Now, my problem with that is that it's flawed philosophy. The idea is that because symptoms may manifest interpersonally, the pathology is dependent on the interpersonal life of the patient or the interpersonal context. And so if you have a patient who, say, repeats the same patterns in relationship after relationship after relationship, certain things are very predictable in this patient's relational life. They've been in a series of relationships, they've been in a series of therapies where the same things seem to happen between the patient and the therapist, the patient and other people. I think that we can make a very sound and logical argument that the pathology here exists or resides within the patient, and it's manifesting in different relationships, but it's not located in these relationships. It's located within the patient. It's the patient's mind. It's the patient's mind brain, if you will. And the pathology is manifesting in different situations in the patient's life. Now, a postmodernist would say, well, there is no pathology. There's nothing true or valid about that claim, and thus you don't have to diagnose the patient. There's no illness to diagnose. I disagree with that completely. I think it's flawed. I think it's scientifically illiterate.
I mean, look, first of all, fuck you. But second of all, I hate to say that agree because it's boring, But the reality is that the pendulum swinging, especially, I think of John Haidt's work, and the pendulum swinging in the last 10 years or so towards postmodernist, post-constructivist, et cetera, where everything or relativism is in vogue. It's certainly understandable. So I'm going to be as diplomatic as I can be. It's certainly understandable that it emerged from somewhere where either the biological reductivists or the absence of self-advocacy or these appeals towards authority, the feeling of being castrated or undermined as I get it. I get it. The challenge, of course, is that now with everything being this giant nebula of non-truth, again,
Yes.
Doug mentioned in our episode that I forget the author's name who wrote Homo sapiens, but speaking to essentially an information theory also, people have Nash spoke to this in game theory too, that there's a difference between information and truth. And right now, we're not going to get lost in the weeds of all these theories on etiology and pathogenesis, but right now we are in that kind of post-truth era, if we can use that word, which is just to say you have all the access to information, the history of the human race or the species, and deciphering truth from noise or truth from information has never been harder. I think most people can agree on that. I'm sure somebody's going to tell me to fuck off for saying that. But the issue with that, and I think it's accurate, is that people don't know how to decipher and aren't equipped to decipher, like you're saying, back to proper training, including clinicians and physicians. And so what it leaves us is not only further siloing and insular, incestuous buttressing to support our beliefs and convictions, which only amplifies the problem, which is only human because we feel scared of the uncertainty and ambiguity and so on. But it's leaving us with these takes that are saying, well, then how do we help somebody, or how do you negotiate that? I agree with you. I can stand pretty strongly. One of the few hills I can die on is that when psychoanalysis is co-opted or bastardized in service of a moral or ontological agenda on the nature of being or moral landscape, it seems to be a problem. Be that to do with the morality skewing towards some sort of rugged individualism or skewing towards there's no such thing as life itself. I don't know, biology, physiology, neurophysiology. And it is a problem because it's super seductive, pervaded academia, 100%. And then the quality of treatment and training, and how do you negotiate that? I don't have the answers. I am just reporting again as the host of this fledgling podcast and trying to say I'm having all guests on all sides. I'm interested in what everybody has to say, but hopefully we all can acknowledge this as a problem, that if a pendulum swings too far in one direction or the other, we're robbing ourselves of this truth or this pursuit of truth. And the intellectual dishonesty, like you're speaking to, is very frustrating when we hopefully can agree on, again, that we're all just trying to help people. The problem is the people on one side of the aisle, if you will, versus the other, saying, well, I'm trying to help people. I'm trying to help people.
Absolutely.
And then we get ourselves into trouble. I don't know how to solve that. I'm not going to pretend to know because I'm trying to be a nice guy, but certainly I can agree with the diplomacy and tolerance and humility of saying, well, biology can exist with psychology can exist with spirituality can exist with physiology. It seems the intolerance for uncertainty, or
Absolutely.
the intolerance for ambiguity, which is what gives rise to discovery of understanding disease, seems to be in vogue. And I don't quite understand how that's being sustained right now.
Yeah. Let's talk for a moment, if you don't mind,
Sure. Yeah.
about about the nature of interpretation. What are we trying to do with a psychoanalytic interpretation? Right. There are some people who, as I'm sure you know and are familiar with in New York, who see interpretation as, well, number one, it's not all that important, but that it's not aiming to get to some actual truth about the patient. And so they don't value it because there is no truth. Again, sort of this relativism. Now, I think from a classical or from an object relations perspective, an interpretation aims to try to get close to the truth. It tries to approximate the truth about the patient's mind and how it works. There are people, of course, who would disagree with that. But the idea from sort of a critical realist perspective is that there's an objective reality about the patient's mind and how it works. with psychodynamic interpretations, which are fallible, imperfect, prone to bias, and to our own subjectivity. But nonetheless, we're trying to approximate some truth about the patient and the patient's inner world.
Right, we would say the intrapsychic landscape, the psychological anatomy, alongside of the interpersonal landscape or topography.
Yes. Yes. Right. But the assumption there in classical and object relations models is that some truth exists. There is an objective reality there that we're trying to get as close to as possible. And we may be wrong, and we may really fuck it up at times, and it's prone to our own countertransference biases and subjectivity. But there is some reality exists, and that the purpose of interpretation, or one of the purposes of interpretation, is to come as close to truth as possible. And maybe we don't ever really get all that close to truth, but we're trying. There is some truth to be ascertained. We're trying to get there, right? And then, of course, there are other people on the other side of the aisle who don't see interpretation that way at all. There is no truth to be unmasked. Everything is co-constructed. Everything happens between you and I.
Well, it makes sense to me. Again, fuck me for being such a diplomat, but this is
I don't know if that makes any sense to
my
you.
practice. I agree with your, of the many purposes, that is absolutely one. You're bringing light where it hasn't been before. You're bringing conscious awareness where it hasn't been before. You're making space, as Shedler would say, where there hasn't been space before. That is a mutative agent that can facilitate change inside of somebody's psychology over a lot of time. At the same time, yes, you're being tolerant of, when I teach or train, I speak to spinning plates very often because I'm lame and I borrow people's metaphors. But you're paying attention to the spinning plates of interpersonal life, of intrapsychic life, of sociological life, of where you were born, when you were born, genetic and epigenetic life, all the overdetermined, as McWilliams would say, multivariate causalities. That's part of the training. And shame on us if that's not part of the training. That's because it's our responsibility. The problem, like you said, it makes sense, is that if you're not tolerant of a objective or subjective reality, nonetheless, there is some frame to an inner working model. There is something going on. There is a brain with a mind supervened on top of it. I don't know how you would practice, right? It's almost like you're tying your hands behind your back. You have to be tolerant of overdeterminism. You have to be tolerant of all these variables operating synergistically that are greater than the sum of their parts. But that seems lost on, again, equally on many sides, on all sides. I don't know how many fucking sides there are at this point, how many dimensions that we're speaking to Tesseracts at this point in the fourth dimension. Nerd alert, I'll put it there. And it pisses me off, certainly. It motivates me to have these conversations because I do think sometimes we straw man each other. I mean, that's quite obvious. I do think sometimes we get in arguments about things that don't, and it's doing a disservice to us and the patient. And it's a huge problem that if somebody, again, I think of just, I can't name names, psychoanalysis, which is such a close to my heart, being used in service of a moral agenda, because it really is being hyper moralized in one direction or the other. It's a huge problem when to me, it's a scientific tool. The science of subjectivity is a science. And so we have to respect that and be tolerant of all the things that go into it. It's bizarre that it's intangible. It's bizarre, like you said, that it's fallible. But if our earnest approximations, our best approximations in earnest, are of somebody else's subjective life, that is a meaningful thing that has causal power. It really does. And that's my bias as a clinician. I've seen it work. I've treated patients for years at a time or months at a time, both, and done enough rotations, what have you. And it's something to be heard and understood and listened to, has a iatrogenic power. And so it's very hard right now, to think of the capacity we have to have, not to toot our own horns, but just to have this conversation without jumping down each other's throats. It seems obviously we get along, but it seems rare. And it's crazy that we're both clinicians, or that I can have somebody having people on, and I'm looking forward to having people on I disagree with more. And yet it doesn't happen. And and yet we're not politicians. What is going on that we're all seeing patients or and yet we're all, like you said, we're the unicorn example. We can't even agree on what a fucking unicorn is.
Yeah.
I don't have the answer, but that's the luxury. I always say that when I teach or train, I don't have the answer. And that's a huge luxury because I don't have to have the answer. But sometimes maybe I feel like maybe I should to help young students or new patients or consults.
Exactly.
Yeah. I don't want to just totally cop out.
Yeah. I guess I want to say one more thing about the future. Where does the field go from here? I mean, two guys, we both value psychodynamic ideas and psychoanalysis. And so, what's happening to the field and where it goes, from here. I mean, I think to my first point about sort of silos, right?
Sure.
It's so easy when you surround yourself with
We're really fun, by
similarly
the way.
trained folks.
Psychoanalysts, yeah, we're great at cocktail parties. We are just so personable.
Get caught up on minutia. Yeah, yeah, yeah. Yeah, yeah. It's so easy to get caught up on the minutia and really esoteric stuff and realize that as you're doing that, the rest of the mental health world is passing you by. I mean, things are happening. The enrollment. I mean, I don't know the statistics because I'm not an insider
Of course, yes.
like you are, but I know that enrollment in psychoanalytic training is declined, and there's lots of problems with attracting people to psychoanalysis. My argument is we need to do a better job integrating this stuff. And that's why I teach in psychiatry residency programs. That's why I taught MSW students. I think it's that to me is the future. I mean, I'm sure these discussions have gone on for decades actually, but
And accepting clinical social workers wasn't, I could be wrong on the date, and I apologize to my institute. Don't Google me. Was in the 80s. I'm almost positive that the first LCSW was allowed to be, or the PhDs were the 70s and 80s, and then the LCSWs were the 90s. And there's still
yeah,
places in New York that don't accept anything but a postdoc. Pretty sure. Yeah.
yeah.
Yes, that's correct. Yeah.
Interesting. Yeah, yeah. The APA, the American Psychological Association, right, sued the American Psychoanalytic Association, right? And so yeah, but huge problems where you get sort of so
Nobody gives a
siloed.
shit.
You start disagreeing
It's
about whether
absurd.
3 times a week
Yeah.
is better than
Yeah.
4 times a week or not, and it's like it doesn't matter, it doesn't matter in the quote unquote real world, right? And that's what I love about kind of interdisciplinary work is you get a lot of exposure to different ideas, different ways of thinking, different ways of treating people, and you realize that not every approach works for every patient. And I guess that's what I'd like to be the take home message today is it's important to think pluralistically. We don't treat everybody the same. People are complex, they're nuanced, and problems are varied. So expose yourself to different ideas, different theories, different. I like to tell the residents that I teach, I want you to read Freud, I want you to read Kreplin, and then I want.
And then I want you to read Gone Girl. And then I want, yeah, because you need everything. No, I'm joking, but I'm not joking. I say to my students or patients and myself, not all these books, which I've been yelled at, by the way, that I need to fill my shame on me because it means you're smart, right? When these are full. So I'm an idiot. But I teach a lot of like, this is a Nancy's book, on psychoanalytic technique, which is super helpful for people who are just learning. But then I literally said, go watch Lord of the Rings. Like, go watch good art or philosophy or good poetry, good fiction, because it captures so much of the human experience that you're missing. I mean, I know it sounds silly, but it's the more interdisciplinary you can get, not to the point of where your brain's falling out of your head, as we talked about in the post-construct, postmodernist, relativist, blah, 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 but to the point where you're tolerant of the reality that you don't know everything. It's back to, I always say personal therapy is an imperative to become anything sufficient or competent enough of being a good therapist. It's like you have to know yourself deeply enough and be humbled enough to be able to practice and accept ACCEPT, the reality that there's so much to learn and that it's a lifelong process. But we say it as a virtue, right? Not as a dynamic. Learning is lifelong, they say in social work school, my experience. And then you're only with people who think the same. Well, so let me ask you, we'll edit that little lull out. So I was told, wait, I'm going to practice on you before we wrap up. Doug made a very good suggestion about, because we were speaking to our shared interests.
Okay.
I'm sure you have interest in comedy and the overlap,
Okay.
mental health and comedy go hand in hand, whatever. So we were speaking to like how Letterman did it and then Colbert and James Lipton did it on Inside the Actors Studio. And these questionnaires of like, so you almost answered. So I don't have a rubric yet. I got to come up with the what the fuck is life questionnaire, I guess. You mentioned books. So that was one that Doug also mentioned. Is there something that the list of the 17 listeners today, I'm going up in numbers, 17 is a good sign. Was there a book, movie, piece of media? This is an easier one. So I'm setting you up a little, that you would recommend that maybe people won't expect you to recommend that you feel is very valuable? Not just obviously Kreplin and Freud. Like, is there something maybe that had a big impact on you? It could have been fiction.
Yeah, yeah, yeah. That's a good question. I don't think I'm prepared to answer that. Let me think for a moment. No, Sure, sure. No, I mean, I think, look, I'm a history guy. I love, I think we can learn so much by studying history and where the field has been. Sometimes you pick up a paper that was published 50 years ago, and it's like, damn, this is really good stuff. This is much better than some of the stuff I'm reading today. And so I guess I'll recommend
Okay.
a book on the history of psychiatry by Edward Shorter. Shorter's textbook, A History of Psychiatry, from the age of the asylum to the era of Prozac. And then he wrote one a few years later, The Rise and Fall of the Age of Psychopharmacology. And it gives you a behind the scenes sort of perspective on drug development, development of the DSM system, and the like. I think the more you can learn and read about history, I think the better clinician you'll
Well, the
be.
past informs the present. The present's not separate from the past. The idea that memory, talk about post-constructed, whatever. It's the idea that we're new every day. The idea that, we wake up with a memory and experience the landscape and anatomy of our mind is based on long-term memory and explicit memory.
Yeah.
I thought you were going to say like Band of Brothers, and I was going to get
Yeah,
excited.
totally.
Yeah, a Fellini movie that I haven't heard of. Have you Saving Private Ryan? Saving Private Ryan's a wonderful movie. Well, thank you so much, Mark, for being here. I very much appreciate it, and having these are tough discussions that hopefully we'll edit it down, and it's because
right.
and I hope in essence, not being flip or insincere at all, I hope that there are people that disagree in the sense that it gets conversations going. It's not like you and I have experienced and discussed. There's not enough good faith disagreement anymore that helps. How is knowledge developed? A whole nother episode we could do, if not with disagreement. God, stop agreeing with me, man. Yeah. Let's go.
Totally. Yeah, totally agree with that. So,
it's good to see you.
Hey, all right, man. Take care of yourself. I'll talk to you soon, all right?